Good afternoon, everyone. Welcome. We are so happy to have you. Thank you for joining us today. My name is Karen Bell, and I'm an Associate Director for Partners for Advancing Health Equity, or P4HE Collaborative for short. We are a national research learning collaborative that aims to bring together various sectors that are working on health equity, including government, academia, community-based organizations, philanthropy, and the private sector. We are based at the Tulane University School of Public Health and Tropical Medicine, and we are sponsored by the Robert Wood Johnson Foundation. Here at P4HE, we convene the sectors that work on health equity to encourage and support them to work together to better understand critical issues related to attaining health equity. One of the ways we do this is by providing spaces for activities to engage with these groups in insightful conversations on timely topics and promote actionable solutions. Today, we're beginning our two-part discussion called Setting Health Equity Visions for Success. As practitioners and researchers, we're often confronted with having to define success for our work. But success looks differently and means different things to different people. And success is measured in multiple ways depending on the field you work in or your personal viewpoints. Today, we will hear from researchers and practitioners in community advocacy, academia, and health law. We will hear about their health equity achievements. We will also learn about the challenges they experience establishing strategies which disrupt and dismantle systems that impede health equity broadly and within their specific areas of practice. With this discussion, we will seek to create shared definitions of success and health equity based on the perspectives of the collective. So we're actually going to start with asking, what do you think about this? You all have valuable opinions and insights on health equity, and we want those to drive today's conversation. We will be using Mentimeter as a way to engage with each other. So you can access Mentimeter by scanning the QR code on your screen or by going to www.menti.com on your browser or your mobile device and entering the code 12651689. Well, and soon the first question for you all will pop up on the screen. It says, how do you define health equity success in your field? How do you define health equity success in your field? So there's a text box there, and you can put in your definition of health equity success in your field. And I'm also going to participate. Again, this is a collaborative. We're all in it. Actually, I'm going to think about it a little bit and see what I think. All right, and you can hit enter. You can actually put in multiple answers. So if this is like, something that you have to think about, or you think of a better answer or a different answer, or even looking at the results of other people's responses as they show up, you can add in your 2 cents, but then you can also add in your additional 2 cents by putting in multiple answers. So looks like we have some answers coming in, 12, 13 answers or responses. Let's see what people are saying. Okay, someone says zero harm is their definition of health equity success. I like that. And I like that that kind of bridges at least the language of multiple sectors, thinking about, or I thought about medicine and how they talk about first do no harm, and also thinking about that concept in terms of health equity, respectable to everyone, community building, definitely, justice. I think that might have been my answer. But yeah, that's what I think. By how much the most marginalized are able to achieve their definition of health. Yeah, definitely. I really like that because you talked about the people who are most marginalized, and then you talked about their definition of health. So even our definitions of health might vary, being unable to predict health outcomes by only viewing demographic data. I like that. So when health outcomes are randomized, basically are random across our social groups. That makes a lot of sense to me. Historical barriers to participation have been removed. Yep, definitely. Redesigning structures and power dynamics as it relates to health systems and processes. Yeah, so that's a lot of rebuilding and removing the removing the barriers. Yeah, measuring reduction of health disparities through legal interventions and policy advocacy. So definitely identifying the tools. Awesome. Thank you all. Equitable opportunity and support. 28 people have responded. 30 answers. Okay. I'm not sure if we can scroll down. Okay. I think we can go to the next question. Additionally, want to note that we point out people's responses and do sort of analysis of what people are saying. So that's cool too. The next question is, what do you think are the biggest obstacles to achieving health equity success? So now you can send in your responses, just type them in and send in your responses, what you think. So we've got some answers rolling in. You can, take your time, come back to it even if you want to, see what other people are saying. And the answers should be showing up shortly. So let's see what happens here in a few seconds. Okay. Racism multiple times, sexism, money. Yeah, we live in a capitalist system that is driven by capital. Legislation against it. Exactly. We have someone who is a health law expert discussing, or will be on our panel today. So that's exciting. Overwhelmed by the endeavor. Yeah, I totally get that. It is it's huge. All of our society creates health inequities. So we have to address these things, sort of big picture thinking, and that's a lot to do. Political will, yep, that links up with the legislation. Different definitions of health equity, and that's one of our goals here, is to come together to think about what health equity looks like, and the different visions of what it can look like. Control of healthcare services in the hands of a few corporations. Yep, exactly. Yeah, awesome. So yeah, thank you all for putting your responses in. Sometimes we'll be able to see everyone's responses, but they're in there, and we appreciate you sharing, because what you share tells other people what you think, as well as giving them ideas. You can also share your comments and your thoughts in the chat throughout today's discussion. If you have questions while we have the panel, you can put your questions in the chat there, but you can also join this conversation with your questions and comments after the webinar, or even during the webinar. If you'd like to live tweet, you can do so by using the hashtag partners, the number 4HE. So if you want to tweet about what you have heard, what you think, comments, thoughts, whatever it is, you can tweet about it by using the hashtag partners 4HE. All right. So I think we will move on to our panel discussion featuring our distinguished guests. So first, I'd like to introduce Colin Killick. He is the Executive Director of Disability Policy Consortium, short is DPC, a Boston-based civil rights advocacy organization run by and for people with disabilities. At DPC, he led efforts to ensure Massachusetts' COVID-19 response protected people with disabilities, and co-led advocacy efforts that since 2014 have persuaded the legislature to quintuple its investment in housing vouchers for low-income people with disabilities. He holds a 2018 Master's of Public Policy from Harvard's Kennedy School and won their RFK Award for Public Service. He serves on a variety of state and national boards and commissions, and is a published poet and voice actor. So Colin, welcome.
Thank you so much. It's an honor to be part of this.
Thanks. Next, we have Jessica Owens-Young. Jessica Owens-Young is an assistant professor in the Department of Health Studies at American University. Her work broadly focuses on health in economically distressed and under-resourced communities. Dr. Young's research centers on investments and policies that improve health through community and economic development, and the roles of race and racism, and how they play in shaping these investments and policies. Dr. Young's current research projects focus on the intersection of community development and health, including the roles and impacts of philanthropy in designing, scaling, and translating community development and health initiatives into policy. Dr. Young is also examining health in economically distressed communities, especially those communities experiencing economic changes or instability. Dr. Young, welcome.
Thanks for having me.
Thanks. And lastly, we have Elise Citrini. She is the executive director of the Jaharis Health Law Institute at DePaul University College of Law. She came to DePaul from a career in legal services, most recently as the manager of Legal Aid Chicago's Medical Legal Partnerships, also known as the MLP project, beginning in 2015. Ms. Citrini is a first-generation Latinx American who chose a career in the law in order to give back to her community and live up to the sacrifices made on her behalf. Elise has worked closely with a wide range of medical partners through her experience with the MLP, and in 2019, she worked as an adjunct professor teaching civil litigation skills in an experiential learning environment. Prior to her experience with MLP, she worked as a staff attorney at Legal Aid Chicago, where she learned to focus her legal advocacy through a racial justice lens, which became the touchstone of her career from that point forward. Ms. Citrini continues to collaborate with the Shriver Center's Racial Justice Institute by serving as a trainer and coach since 2017. She also lectures at DePaul, Loyola, and Northwestern Law Schools on implicit bias and structural racism. Elise, thank you for coming and welcome.
Thanks so much. I'm really excited to be a part of this conversation.
Thanks. I'm excited too. I'll actually get started with you. What is your vision of health equity, and what does it look like in your work?
So yeah, I really appreciated all of the different conversations that were, the different definitions that came up through the opening chat. I thought that was really interesting. And I, kind of mirror and agree with so many of those definitions. In my work, my idea, my understanding of health equity is really to reduce the differences in outcomes. So when you see disparate health outcomes, we want to utilize policy tools, legal advocacy tools, really just every tool at our disposal, and through multidisciplinary ways to really get at reduction of disparities in outcomes. So when I think about health equity, I loved that definition that someone said, where you can't just look at demographic data, or what I like to do in Chicago, at least, is looking at zip code data and then make predictions about what health outcomes are going to be. I would love to get that to not be the case, and that would be my definition of success. And again, the way that I do that through my work is, again, through this multidisciplinary lens, working with medical providers, working with public health professionals, working with attorneys and policymakers, to try to see what are these root causes that are affecting health outcomes.
Thank you. Thanks for getting us started. Dr. Young, what do you think? How do you define health equity?
I mean, it's pretty similar, really. And I also appreciate all the different definitions that came through in the opening questions. And what a neat platform that is. I had no idea about that. So thank you for including that. So my way of thinking about health equity, I think about like the how and the why of different processes. You know, ultimately, the goal is to eliminate the differences in outcomes that we see based on socially assigned characteristics, right, or categories. But I'm also interested in the how that we do it. So making sure that people are included in not just, you know, providing minimal input in the beginning of a project or an investment, but that people who are closest to the problem have the solutions to these problems. So ensuring that they are included from the whole range of activities related to health equity. And you actually read my definition of health equity, and it was the one about the most marginalized being able to live their definitions of health, right? And one thing that I like to talk about with my students is that there are multiple ways to define health. And I think that having a health equity lens is recognizing that and also using that when you design your different projects. And so how it shows up in my work, again, it's about the how and the who. So one example is who I partner with to do this kind of work, who I get ideas from, right? My role to me as an academic is to facilitate the transfer of resources from people who have power to those who know what to do with it, right? And so I see myself as that conduit. And so when I'm applying for grants, for example, I tend to apply to programs that have a community focus or requires a community-based partner in order to even be eligible to apply. And so I'll probably talk more about some of those programs later, but that's just a flavor of how I approach health equity.
Thank you. I'm going to ask the same question to Colin, but first I'm going to point out why I had a little bit of difficulty in asking the question. I think Elise and Jess, to a certain degree, pointed out how we talk about health equity, mostly in academia, in sort of these rarefied spaces, that it's really just about the differences in health that we see across specific groups, which I totally agree. But when I was thinking about this from a disability studies standpoint or disability policy standpoint, I wasn't sure if that sort of framing of health equity was the same. And so I agree. I'm really glad that we were able to do that activity and see people's responses and definitions of what health equity is. But I'm asking Colin, how do you view health equity success, particularly from your standpoint in your work? What do you think about it?
Yeah, thank you, and thank you for raising that in our preparation, because it is a really interesting question for our community. People with disabilities are often left out of the health equity discussion because a lot of health equity discourse focuses on health discourse more broadly, focuses on preventing disability, which is not necessarily a bad thing. Obviously, ideally many forms of disability we want to prevent, but it means that we get seen as a failed health outcome instead of a community. And therefore, once people become disabled, they're sort of written off because people don't necessarily know what success looks like, because they have this narrow definition of health that is purely focused on clinical outcomes. And so what do you do with people who aren't going to get better? And even on that clinical dimension, right, there are critical health equity concerns for the disability community. The fact that, most OBGYN offices, a large share at least of OBGYN offices and dentist offices mean that people with physical disabilities, mobility disabilities, have significantly worse oral health and reproductive health, even though there's no inherent reason why that should be the case. The phenomenon of diagnostic overshadowing means that people with mental health diagnoses get considerably worse care for their physical illnesses because symptoms are misattributed to the mental health diagnosis. But we try to think of health more broadly and more functionally. So there's a lot of discussion, quite rightly, and certainly impacts our community, about social determinants of health. We also kind of have the reverse. We have health-determined socialization, and like for many people with disabilities, getting access to quality health care is a necessity for being able to live independently, being able to work, being able to see your family, being able to participate in your community. If you don't get those critical personal care attendant services, durable medical equipment like power wheelchairs, et cetera, you wind up institutionalized or homeless or dead. So healthcare is just as a general disability policy organization, healthcare is most of what we do because it's so critical for our community.
My mind is a bit blown, so I'm trying to not portray it in my face. What you said about health determinants of socialization. It makes me think of like a very broad definition of health, of wellness, of well-being, being able to be a part of social society can sort of be understood as a vision or a goal. Is that sort of aligning with what you're talking about, Colin?
Yeah, absolutely. And so our organization, before my time, which we're in the sort of late 2000s, early 2010s, was part of, did a report on disability and health equity, and it wound up being pretty influential on the creation of a specialized health program in Massachusetts, a pilot called OneCare for disabled people who are eligible for both Medicare and Medicaid. And one of the key facets of that program was that every member should write, or be helped in writing, but they should play the lead role, a set of healthcare goals for themselves that's spelled, and that should be the core of their care plan. So each person should get to determine for themselves what their healthcare goals are. And so like, I want to be able to go to church every week. It can be a healthcare goal. Or like, I want to be able to get a job. I want to be able to travel, I want to be able to have a pet, what have you, is a healthcare goal. And it's the job of the plan, of the medical infrastructure, to support people in attaining those healthcare goals, whatever they have to be.
Wow. Okay, thank you. That was deep. As my aunts like to say, that was deep. I wanted to come back to Jess though, because it literally was kind of what you were just saying, that there's different definitions of health. And so maybe you could talk about, or this could be a place where you could talk about your work a little more, but could you talk about some of the different definitions of health that you come across in the work that you do?
Yeah, absolutely. And so, there's the academic definitions of health, right, that we see in the literature, but I like to go back to my students. And so I teach a course on multicultural health here at American, and this course attracts a lot of different students, so not just our public health and health studies students. And so one of the first things that we do as a class is to create a definition of health. And so I asked students to just jot down some ideas, put it on a Post-it note, and really throw it up on the board. I'm old school, all right? I like tactile things, right? So we put it up on the board. We have people walk around, and it's so interesting to see how like people's hometowns, like their geographies, their socioeconomic backgrounds, all of these different social factors play in shaping how they perceive health. And so you have people just talking about, the physical, right? Being free of illness, for example. But you also have students talking about a whole range of mental, emotional, and social well-being that's a reflection of their own upbringing and what they feel they need in order to carry on their everyday lives. And so by the end of that conversation, we do come up with our own definitions of health, which do change from semester to semester, which is also interesting, especially post-COVID. But this webinar isn't about that, right? But all that to say that we all have our perceptions of what health is, and that shapes what we think is necessary in order to maintain that health. One of the projects that I am working on is funded by the Robert Wood Johnson Foundation as a part of their Interdisciplinary Research Leaders program. And our project is working with the Capital Area Food Bank to evaluate their Client Leadership Council program, which is a 10-month political advocacy program for clients of the food bank, right? And so this reflects my ideas of health equity and what health is, because we often don't talk about political health, the ability of communities to engage in the political processes that create the policies that affect their everyday lives. And so I'm really excited about this project, because not only will our findings strengthen and refine the theory of change for the program, it will also serve as a model, not only for other food banks, but also other human and social service organizations.
Go ahead, Colin. I see your hand up. I appreciate it.
Thank you. I just wanted to strongly endorse Jessica's point there. The core of what we do is an advocacy organization, right? Doing policy advocacy, organizing work. And it's proved a real challenge. We've gotten a lot of, pushback from funders. We've been told, like, you have to do service delivery, like the philanthropic world is very uncomfortable with advocacy and politics. They're seen as too close to lobbying. But these are structural problems that cause these things, right? They are systemic problems. And so to me, like, the insistence on, oh, well, you can't do politics, you can only do service delivery, is akin to saying you can only treat the symptoms, you can't try to cure the disease, right? And so it's so excited to hear, and Jessica, I feel like you and I need to talk about that program because it sounds really cool.
We love to make connections even on the panel. This is a collaborative, so I appreciate this happening right here live and in person. What you described, this concept of treating the symptoms and not the root cause, what's causing it, makes me think about how different fields, different sectors define health and different health approaches. And so I want to ask you, Elisa, about, you're talking about multiple things, the law, health law, as well as, doctors and healthcare. Like, how do you see potentially differences or similarities, and how do you navigate that in terms of those different sectors or groups defining health equity, what the success of health equity is? What do you see there?
Thanks. Yeah. So I kind of rely on my own personal lived experience of being sort of a cultural translator. So I grew up, my parents are immigrants. My dad didn't speak English. My mom did, and she actually worked in the health field. So I sort of grew up hearing vocabulary, understanding kind of how medical systems work. But I also grew up sort of literally translating for my family members who didn't speak English. And so I've kind of taken that concept of cultural translation as I've been in these really interdisciplinary, multidisciplinary spaces where I have to act as cultural translator and learn the vocabularies of health systems, translate that kind of for my law students and for my legal partners and for my clients in terms of what are the legal advocacy tools that we can use to address some of these health harming issues that have actual legal solutions. So this concept was really useful to me in terms of like cultural translation, understanding goals and needs from healthcare provider side for their patients, figuring out from patients, and as Jessica and Colin were both saying, from patient communities about what their goals are. Because frankly speaking, legal service providers historically have had this sort of very paternalistic view of these are solutions, these are some tools that we have that we can offer you, community. And if your problem fits within our framework, then sure, great, we can help you. And if it doesn't, then I'm sorry, but there's not much we can do. Utilizing these multidisciplinary, like newer tools, we can flip that and try to work upstream for looking at some of those root causes to the structural issues that we've been talking about, and really listening to community members. What is it that you need help with? What is it that you need translating for? What is the vocabulary that you need to build, the tools that you need to grow so that we can empower those communities to advocate for themselves? Because it's very true. Legal services, everyone that we're talking about here has limited resources. We're working in a world of limited resources. And so how can we amplify? How can we increase the impact that those limited resources can have? And that really is through community empowerment. And Jessica just hit the nail on the head. Those communities have the answers. They know what solutions can work. And so we, like coming from an attorney's framework and an advocate's framework, what are the legal mechanisms that we can utilize to help those communities get where they want to go? And then again, working with healthcare providers, public health, behavioral health folks as a real interdisciplinary team, both on the individual level as well as in the community level. That's kind of where I'm coming from.
Yeah, no, that makes a lot of sense. And I'm really resonating with this idea of being like a cultural translator, or like a translator between different sectors, because again, that's what our collaborative is all about, like having cross-sector conversations and collaboration to achieve this goal, or these goals of health equity. I'm thinking about that particularly for you, Colin, right now, as someone who does policy work and potentially having to explain disability as, or even the concept of disability, let alone disability as an equity issue, a health equity issue. What has that been like for you? Maybe being a translator, like explaining the work that you're doing for the people who have, at least in the sense that we talk about power, policymakers and politicians. How has that been for you?
Yeah, it's been a challenge, and it's had intense consequences. When we wound up leading the Massachusetts disability community's response to COVID, and more to the point, to the state's COVID policies, and we were having to explain things like the fact that many people with disabilities couldn't leave their houses, but were still going to be exposed to COVID because their, personal care attendants and such are going to have to come in and, see them. So we, pushed the state into setting up a home vaccination program. But more to the point, we had to fight back against crisis standards of care, right? Rationing guidelines for ventilators when it looked like there weren't going to be enough, which sent people with disabilities to the back of the line to get that treatment. And, in some states it was particularly overt. Alabama said that they wouldn't admit anyone with an intellectual disability to the ICU if COVID rates got high enough. But even here in Massachusetts, anyone with a condition that would limit their life expectancy went to the back of the line. And I think a lot of this is just a kind of stigma around disability. And the opinions of disabled people about disability and non-disabled people about disability are, and especially doctors about disability, are radically different. There's a study from, I think it's 94, of emergency physicians looking at spinal cord injury. And they asked a sample of emergency physicians and a sample of people, they asked them, would you, among other questions, would you want to survive a spinal cord injury that resulted in paralysis? And then asked a group of people with similar spinal cord injuries, are you glad to be alive? It was less than 20% of the physicians reported that they would want to survive such an injury, compared to more than 90% of people with the condition saying they were glad to be alive. And those physicians, they weren't just saying this for themselves, they also, in the same survey, a large share of them said that they felt that methods were too aggressive, that too much was done to keep people with spinal cord injuries alive in the aftermath of traumatic accidents, because their quality of life ought to be taken more into consideration. And so this is a big one that we come back to. We're actually trying to pass legislation in Massachusetts around this. Our community gets our quality of life defined for us. And medical decisions and policy decisions are made about us based on the presumption that our quality of life is low. Lisa Iazzoni out of the Mongan Institute at Harvard just done a ton of work on this. And our assessment of our quality of life is very different because we value different things. We have our own perspectives. And, for instance, being independent, is not necessarily about being able to do everything yourself. It's being able to control what you eat, when you get up, when you go to bed, etc., regardless of whether you're doing it yourself or someone who works for you is doing it for you. So I could, in the interest of not dragging on, I'll cap it there. But yeah, this is something we really have to explain, along with just disability being a cultural phenomenon, a phenomenon that is defined by policy, where people with the same condition can have very different experiences depending on whether their needs are accommodated or not.
Thank you. We specifically asked you to join us because we don't think about disability and thought about how this conversation would help a lot of people who are watching this really just learn sort of the basics. So I really appreciate that. And I think that you're framing a lot of the obstacles that people can come up against when doing health equity work and working toward their vision of success? Dr. Young, I was going to say Jess, but Jess, yeah. Jess, you come from philanthropy into academia. And so I wanted to ask you about obstacles, either broadly or specific ones, that you see in the field or realm of philanthropy in seeking to achieve a vision or visions of health equity.
Yeah, funding is a huge challenge for folks working in this field. One, there never seems to be enough funding to go around, or what gets funded is underfunded. There are also structural challenges within the field of philanthropy. So there may be rules around what types of organizations could get funded. So like a 501c3 versus a C4, or folks are limited on the political activities they're allowed to do while being funded by certain organizations. So structural things like that. If you have to have a fiscal sponsor, right? If you're not formally incorporated as a 501c3 or another organization, do you have relationships with people who can serve as fiscal sponsors to receive the funding and then funnel down to support your work? There's other structural barriers that relate to, once you get the grant, what are the reporting requirements? Are you required to report quarterly, yearly? Do you have the staff to gather the data and interpret the data that you might need for those reports, things like that. There's also just the limitations that I've found during my time in philanthropy, and also still being connected to that field that I'm hearing today, such as building the relationships with community organizations that would help expand the investments that they are trying to make. So for example, trying not to only rely on the same 3 organizations or the same 3 folks that right? Being cognizant of the efforts that are needed to expand the networks. I can go on with this, but one more that I would like to highlight is also investment within the communities to build their capacities to do certain tasks. And so often we see funding streams that focus only on delivering some kind of service or program. And that's it, right? You have this for 3 years, maybe 5 years, right? The length of the grant is also a structural challenge. But you have this for some time. We want you to deliver this program. We want you to report back, and that's it, right? There may be no investments in building, for example, the internal evaluation capacity of the organization that's being funded, or providing pathways for community members to gain those skills so that they can be employed by these organizations to do some of those tasks. I will say it's not all doom and gloom, right? I am very happy to be working alongside with some funders who are very cognizant of their power and positionality, who are taking time to invest in themselves in order to refine and revise their internal operations to make, for example, application processes more equitable, right? And so people are starting to get it, but you still have some of those funders who stick to particular rules. It has to be a certain type of organizations. It has to be these people that get the money. And so those are a few examples that, again, I could teach a whole semester on philanthropy and public health challenges, but I'll stop there.
Hey, no, thank you for sharing those sort of high level, but also sort of insider obstacles that come up in the philanthropy world. What I'm thinking about is this concept of community capacity building. And it made me think of something that you were talking about, Elise, earlier and in our planning call about communities and the social determinants of health. And I was thinking about how some people talk about like racism or sexism or like the isms as social determinants of health, but like in health law, or the health law literature argues that racism, and specifically like systemic or structural racism, shapes the racial inequities in social determinants of health. And so I was wondering if you could speak about that, even thinking about this concept of community capacity building, how something as big as structural racism shapes those inequities in the social determinants of health. What do you think about that?
Yeah, I can actually give kind of a example from some of the work that I did when I was working in legal aid. So one of the programs that we had was designing this medical legal partnership with Cook County Health, which is the largest safety net hospital in Chicago and Cook County. And a piece of that required this community engagement component. And if anybody knows anything about Chicago, about the west side of Chicago or the south side of Chicago, it's one narrative that is constantly told, that is portrayed in the media, and that we hear about all the time. But going into those communities and working with those community groups and with like students and just people who are living in the west side, which is where the hospital is located, it is so asset based. There are so many community assets. There are so many just amazing health promoting activities, health promoting spaces that exist, but we have structurally designed our city to be segregated, to be disinvested in those areas, in those communities. And so we have these systemic historical vestiges that create the health disparities that we see in the outcomes. We see the disinvestment, economic disinvestment in those spaces that lead to economic realities and necessities for some of those community members to make choices that are antisocial choices that lead to things like lowered life expectancy on the west side of the city of Chicago. So we have this really strong like counter narrative that's happening. We have community members that have a lot of like internal and community-based assets, health promoting activities and spaces, and a lot of resilience and a lot of need to have that part of the story told. And then, again, we have the structures, the policies, the policy choices that lead to, the disparate outcomes that we're seeing in the Black and Brown communities that make up the west and the south side of Chicago. So what, what can we do about that? Number one, we can highlight those community stories. We can highlight the health promoting activities that are already going on, and we can move and advocate that they be adequately funded. So these folks are creating incredible art spaces, spaces for community gathering, like learning, physical activity, all on a shoestring. So these are the stories, number one, that need to be told and that need to be promoted so that we can get them, that those folks can advocate for proper funding to create better health promoting, increase that, like scale up those health promoting activities.
Yeah, I appreciate you giving those examples, particularly the concept of counter narratives, because that is a key anti-racism, health equity tool, but also not stopping there, broadening it out to talk about the need for advocacy, policy advocacy, but also creating those spaces within communities that have been disinvested in. So yeah, I really appreciate that. I wanted to potentially close, but yeah, sadly close. But ask each of you if you could share a health equity success story, whether it's big or small, or I think what we're trying to show is that you can have success like across a spectrum, like huge wins, but also small wins that lead to huge wins. So if you could share a health equity success with us? That would be amazing.
Start. So kind of going back to that program that I was talking about, we started this medical legal partnership with Cook County Health through a grant. It was a grant funded program. They gave us 2 years to provide services, to like do this research, and so that we were funded for 2 years. We showed that not only was the programming helpful and like created health, like positive health responses and feelings among the patients that were surveyed, we also had like a positive return on investment for the health system. And so the health system, so Cook County Health picked up the program and they put it into their own budget to continue the funding for that medical legal partnership. And so that to me is a huge win. It's showing that, we can show through this interdisciplinary partnership, these legal interventions, benefits to individuals as well as benefits to our health systems, so that they can provide, services to even more people.
I can talk a little bit about one of my other research projects and what we're finding. So one of my projects is evaluating the use of telehealth among local WIC agencies and clinics in DC during the pandemic and now. And I will have to say that some of our findings are showing that the disparities that we've seen in like technology access and use for health purposes is closing. And so one example from that project is just how the use of public spaces have supported being able to use telehealth. So like, for example, the library, right? When government public health agencies have relationships with libraries, they can spread information about like WIC programs and increase enrollments, but also open up those public resources or make people more aware of those public resources that they can use to access those types of benefits. And so that kind of partnership, I think, is a health equity success.
And actually, I was going to mention a different one, but Jessica, your point reminded me. There's new data coming out showing, so people with disabilities are among the least employed of any minority group in America. Our workforce participation rate is less than half that of the general population. But new data has come out showing that disability unemployment is actually falling faster than that of the general population, which is to say the gap is shrinking. And the reason for this is because of the widespread adoption of remote work, because disabled people had been asking for decades for the ability to work remotely as an accommodation and had been consistently rejected and told that it was implausible. And now that remote work is becoming the norm increasingly for everybody, a lot of disabled people who were previously shut out by inaccessible workplaces, inaccessible commutes, etc., are now getting jobs. And obviously there are intersectional implications of that. We're actually trying to get funding to study whether gaps are opening up within the disability community based on race or based on language, etc. But still, on the whole, good news. And I think points to something that's important, which is things that are seen as accommodations, as benefits for a small group, can be actually benefits for everybody. As I've heard this called the curb cut effect, right? 99% Invisible has a wonderful thing on curb cuts being developed for people with disabilities and are now used for people in strollers, people pulling luggage, etc. Captioning on television was only made nationally available after a lawsuit by the National Association of the Deaf that's now used by so many people. So I think that's hopefully a good hopeful story that things that emerge out of these marginalized communities can wind up being beneficial for everybody.
Great. Those are great examples, inspiring examples, and teaching examples. So I really appreciate you all sharing. There's a specific question in the chat for Elise for a list of initiatives in Chicago. If either of you all or any of you all have any additional information that you'd like to share in the chat or maybe email it to us later, like we can share it with members of the collaborative. But I just want to personally say thank you all for participating, your thoughts, your expertise, and just sort of being vulnerable with sharing your experiences, because even that, talking about the obstacles and the things that people have to go through to work toward these health equity visions of success is necessary. So we really, really, really appreciate it. Thank you so much.
Thank you, Karen, for having
Thank
us.
you. Of course, of
Yeah,
course.
this is great. I really appreciate the conversation. It's just very thought-provoking and exciting. And I love the Chicago shout outs in the chat.
We love that. We love that. Okay, well, thank you all. We are going to, thanks. We're going to move on to get your perspectives, audience members, about this topic, given either what we've said, what you've learned, what you've thought about. You can go back to menti.com. I'll do the same so that we're all in this together. Actually, it should already be up if you already have Menti up. The next question, in your view, what are the next steps to address health equity? And I'm actually going to write down something that Colin wrote or spoke about. So you can go ahead and put in your responses for that question. In your view, what are the next steps for addressing health equity? Great. You got some people, you can put in multiple responses, and we'll go from there. In your view, what are the next steps to address health equity? And whenever you're ready to show the responses, I think we can do that. Standardize the definition, having networks, bug legislation until they are sick of hearing and seeing me. We love that. We definitely need more community organizing around advocacy, community empowerment with funding directly to groups and mutual aid organizations that know what is needed for health promotion. Definitely. And I appreciate Elise for showing that or telling that a lot of this work is already happening within communities, but we have structural inequities that cause the social inequities and health inequities. So thank you. Awareness, all of that. Thank you so much. And the responses are still coming in. Educating people, awesome. Okay, I think we could go to the next question. The next question is for the P4HE Collaborative. What action steps would you like to see the collaborative take next? What are you looking for the collaborative to take next? Right. What are we looking for from the P4HE Collaborative? Since you're here, your voice might as well be heard. Since we mentioned that as a goal for next steps in health equity, we can do that here. What action steps would you like the collaborative to take next? I think we can show the responses. Okay. More funding, promote NOVA classification of foods, continue expanding nationally, concrete action plans, definitely funding, more opportunities for members to talk and discuss their work and views. Awesome, we would love that. Great. You can always tweet about us, email us, clearly help define health equity nationally. Incorporate more political health concept training. Okay, we hear that. That's definitely necessary. It came up. More webinars like this. Well, we like to hear that. I really enjoy these webinars and hopefully they are extremely helpful. Okay, so with that, we want to thank you. We want to invite you to join us on Tuesday, April 18th for part 2 of this webinar. We'll have more guests who are talking about health equity success. And also we look forward to hosting on April 19th, our second session of our workshop series called How Do We Know When We've Achieved Health Equity? So that's a workshop series on measurements. More information about our upcoming activities is on our website. You can follow us on social media and help us spread the word by sharing our content that most interests you in your work. See you in April.